redundant for you, please feel free to zone out a little bit, but try to make this interesting. I'm a pulmonologist. There's a group of 8 of us in pulmonary at Virginia Mason, and I'm here to talk about some asthma updates for you today. I have no disclosures. I'm going to go over fundamentals of treatment and really just emphasizing inhaled corticosteroids. I'll be using a lot of acronyms, so ICS is inhaled corticosteroids. I'm going to talk about our asthma control tests and what we do to step up, step down our patients, something that's easy to implement in clinic. I'll focus on different triggers for asthma, specifically post-viral asthma, because a lot of you are seeing patients after they have a viral illness or COVID with new onset asthma, and then how to set expectations with them and how to change care as they go through their disease course. And then I'll spend time on biologics, especially after our rheumatology talk, kind of reflecting what the biologics are for pulmonary, what special considerations we have in asthma biologics. And if we have time, I have some extra pearls that my primary care colleagues have found helpful. So I threw in some slides that they found helpful. So starting with a case, this is someone I saw about a year ago, an 81-year-old guy who hadn't smoked that much. He had some dyspnea, so was in my office. I had normal stress echo within the year. He was not sure what else was really going on. He had a known history of an elevated hemidiaphragm he'd had for years, but this new dyspnea was more recent over the last year or so. He feels winded when he's talking sometimes. He has nocturnal symptoms. About once a week, he'll wake up coughing and short of breath and kind of feel anxious and have to sit up and slow his breathing. He does have sputum production in the morning. It's frothy and white. And again, with that anxiety, he does take benzos sometimes and it helps, but it doesn't totally cut out those nocturnal awakenings. So we got pulmonary function tests again on him. And I'll go through this slowly just to kind of recap what we look at PFTs. Not that you're going to be interpreting them, but in general, what we want to see is the ratio, the FEV1 to FVC, which is the amount of air that comes out in the first second compared to 6 seconds. So the tighter the airway, the slower the flow. So the lower that number. So 70 used to be the cutoff for obstruction. We have a sliding scale now for age. It's a little more appropriate. So we use a lower limit of normal. So for this guy, his reference is 75 or 0.75, and the lower limit of normal is 67. His ratio is 65. And if you look underneath that is FVC, which is the 6-second measurement, and the FEV1, which is the 1-second measurement. Those are low, 1.7 and 1.1 liters, which is 38 and 34% predicted. So he has smaller lungs because of his elevated hemidiaphragm. And then when we give him a bronchodilator on the second half of the table, the size of his lungs got bigger. He had a 13% improvement and a 15% improvement in his FVC and FEV1. And he actually wasn't qualifying as obstructed at that point. So in that second post-BD column, he now is within the lower limit of normal. So this is good PFTs to represent airflow obstruction with reversibility. So what would be your first inhaler for him? What would you start? So SABA, short-acting bronchodilator or albuterol. Alama, which is our long-acting muscarinic antagonist, or Spiriva. ICS LABA, you'll hear me say that a lot. The LABA is the long-acting beta agonist. Or ICS formoterol, sorry, I spelled that wrong, is a specific kind of LABA that has quick onset and long duration. So I'll be referring to those differently because it is because of the pharmacokinetics of that is unique. Or would you prescribe an ICS with a short-acting bronchodilator? So the answer to this question, there's actually like 3 potential right answers. And it depends on if you're using the GINA international guidelines or our national guidelines. And it kind of depends on the patient and how you think he's going to tolerate treatment. So what I want to do is go through that. Basically, you could give choice 3, 4, or 5, and kind of go through the fundamentals of why those different options could be appropriate. Before we dive in, just going over the diagnosis of asthma. So asthma clinically is diagnosed clinically. It's hard to always have objective data, but there's a real push to get objective data. But normally people are sitting in your office complaining of wheezing, shortness of breath, chest tightness, maybe cough, productive with frothy phlegm. Ideally, we want to also see obstruction on their PFTs. Now, obstruction doesn't have to be all the time. Asthma waxes and wanes and comes and goes. So you want spirometry that either shows variation over time or broncho responsiveness, that improvement in their FEV1 and FVC with albuterol. We have a lot of peak flow meters in our clinic, so I hand them to patients that are really a little more savvy and want to like see if this is really asthma. Then they take their peak flow through the day, and seeing a change of 20% really indicates asthma. There are times where we just do therapeutic trials and see if you feel better with a short-acting bronchodilator quickly. But ideally, we do that with spirometry or a peak flow to see a number that's improving, not just subjective symptoms. And then bronchoprovocation, I'm not sure about PFT access here, but in Seattle right now, it's actually hard to get these tests done. This is an ideal way to diagnose asthma. We basically have them inhale an irritant, either methylcholine or mannitol, and everyone becomes bronchoreactive at that point. But the percentage of which you react indicates whether or not you have asthma. But again, that test we don't do as frequently. So I'm going to go through the global initiative for asthma is the GINA guidelines. So these are the global guidelines, and I'll also in a few slides go through our national guidelines, but I'm going through them independently because I want to point out differences and kind of show you the idiosyncrasies of how we're being told to manage asthma so you can make the treatment plan that's right for your practice and your patients. So going through this slowly, GINA's first recommendation is actually to change your reliever or your rescue medication. So they're really pushing to not prescribe albuterol for the as-needed inhaler. Instead, they want you to use albuterol with formoterol, which is Symbicort or Dulera, which not all patients have on their repertoire of covered drugs. So I'll get into that. But ideally, the reason being is when you're treating with a short-acting bronchodilator, you're fixing the problem temporarily, but you're not treating the underlying cause. So this is actually treating the airway inflammation that's causing the airway obstruction to begin with to help stop the continued cycle. And then for step 1 and 2 asthmatics, so these are mild intermittent or mild persistent asthmatics, they would just have you use this combo inhaler as needed. So as needed, ICS formoterol. Then for our higher step 3 through 5 asthmatics, so people with more symptoms where they need a maintenance inhaler, the idea is MART therapy, M-A-R-T, maintenance and reliever therapy. So actually using the same inhaler twice a day and then PRN throughout the day, which is great. If your insurance is going to pay for 2 inhalers a month for these people and everything, that will work out well, but not always the case. But the reason for this, I'll get into those details in a second. They do have an alternative. This is their track 2, so their less ideal treatment, which reflects better the NIH's support. But they say for step 1 asthmatic, you can use an albuterol or short-acting bronchodilator. And when you take that, take it with Flovent or QVAR, take it with an ICS alone. So you're getting that, that anti-inflammatory component as well. So that's in the step 1 here. And then step 2 goes into maintenance. And then step 3 through 5 will include the MART therapy. So as well as other drugs we're adding on to control these harder to control asthmatics. So the reason for that switch, so first theoretically, so short-acting bronchodilators, if you're using them, they down-regulate the beta receptors. The more you use it, the less beta receptors you have, the more rebound hyper-responsiveness you have, and the decreased bronchodilation you get with each dose. So it's actually, there's a tachyphylaxis with this drug. And there's increased allergenic response, and we've actually measured increased eosinophils in the airways for patients who are using their albuterol a lot. In observational data, we've seen that if people fill more than 3 canisters of albuterol a year, they're more likely to end up in the ER. If they fill more than 12 a year, they're more likely to end up in actually higher risk of death. Now, causation there is not clear. This is objective data, but we've done some RTCs. So this slide, and it'll all file in, is a quick summary of the studies that have come out since 2019. So there is 2 studies. One, the Sigma study, was industry sponsored. I think the other one, Novel Smart, was not. But they looked at using albuterol versus using ICS formoterol as needed for step 1 or 2 asthmatics, so low intermittent asthmatics. And they found that the risk of severe exacerbation decreased by 60 to 64% in both of these studies. Additionally, looking at the same asthmatics, if you use maintenance, so if you're on twice a day Advair or Symbicort compared to the as needed, in 4 different studies, the risk of severe exacerbation is the same, which means that if you are taking it just when you need it, you're just as likely to end up in the ER needing steroids as someone who's taking it as a maintenance therapy twice a day. There were some benefits to twice a day. There was slightly improved symptoms on like different questionnaires, a slightly better FEV1, and a slightly better decreased FeNO, which is the fractional excretion of NO. So that kind of favored using maintenance therapy, but you had 30% less use of your inhaler, of your inhaled corticosteroid, using it as needed with the same like primary outcome, which was severe exacerbation. So all in all, they're saying there's not enough difference between maintenance twice a day and as needed for these step 1 and 2 asthmatics. So that's why they've moved to just as needed ICS formoterol instead of albuterol. Caveats to this, all of these studies use Symbicort. The other medication you could use is Dulera, because that also has formoterol. Max dose is 12 puffs a day. That can cause a lot of thrush for some patients because each time they're getting a puff, they're getting more exposure in the oral pharynx. So that risk is increased. You can't do this with Advair or Brio. All the dry powder inhalers in the US do not have formoterol. So it's specific to ones that have formoterol with a quick onset of action. So it acts as quickly as albuterol, but it just keeps acting. Otherwise, it won't work as a rescue. And then you kind of have to know your patient. So if this is someone who won't recognize what's going on, won't be able to say, oh, I need that inhaler, or oh, I'm never that bad, but they actually are bad, then they're not the right person to be on as needed. They need maintenance inhaler. And this is just a highlight. So you can have Dulera or Symbicort for your ICS formoterol. Advair, Air Duo, Brio, all those other ones wouldn't work for this. This is the NIH guideline. So this is the focus of like what the US has said is appropriate for our patients with our insurance system. But this was updated in 2019 before all those studies were published showing that the ICS formoterol is better than short-acting albuterol. So they're a little behind, but they still, if you look at this, so they think, okay, step 1 asthmatic, they're only using the inhaler a few times a week, give them albuterol. But once they're starting to use it more, we want them on the inhaled corticosteroid twice a day. And then their step 3 is the same. This is MART therapy, daily and as needed ICS formoterol. So they're from step 3 and beyond, the recommendations kind of meet up. This schematic is kind of confusing, but it's just to help you picture like what they think is better to use and what is not as good. So we just don't want, we used to say no unopposed LABA, no unopposed long-acting bronchodilator. And now we're starting to think, well, we really shouldn't have unopposed short-acting bronchodilator either. It's the same theoretical risk, and actually we're seeing clinically it's a similar risk. Instead, we'd rather have inhaled corticosteroids as much as we can whenever they're using it. So what do I do in practice? Because this doesn't always work with insurance companies. So what I do, and what you guys can make your own practice out of this, but I typically prescribe an ICS LABA for patients, or ICS alone if their insurance won't cover formoterol, including inhaler. And what I do is if they can't get Symbicort or Dulera, I prescribe Flovent and albuterol. And I have them keep their Flovent at home by their toothbrush. And during the day, if they use their albuterol, make sure they take their ICS at night. So they're taking it as needed. It doesn't have to be the exact same time. But this is what I found has worked for my step 1, 2 asthmatics who can't get Symbicort or Dulera. It just really helps because I want them to get the inhaled corticosteroid. That's actually treating the underlying cause of the airway inflammation. But it doesn't always work with their insurance companies. So that works for us, for me and my patients. If I can, I do prescribe the MART therapy with Symbicort and Dulera. As far as running out of inhalers, this doesn't tend to happen with your step 1 and 2 asthmatics because they're not using it all the time. It's as needed. So they fill it still once a month. But once you get to step 3 and then definitely 4 and 5 asthmatics where they're always using their maintenance and then they need the breakthrough Symbicort as well, they're going to run out of inhalers. So some things work. Sometimes I'm able to get them to fill the prescription twice a month and we have to do a prior auth for that. Other times I prescribe 2 inhalers. They're on Advair twice a day and they use a Symbicort as their breakthrough. So that way they're able to like get it covered by insurance and not pay $300 a month for that extra inhaler. So those are tricks I've worked out, but and I have more to come in further slides. And then, so reassessing is a big component of asthma, making sure you're constantly trying to step down when it's appropriate and keeping them on maintenance therapy when it is appropriate. And this will come up again when I talk about the viral associated asthma exacerbations. So if they're uncontrolled, you're starting inhalers for the first time, we really try to see them back within about 2 weeks. To make sure they're using the inhaler right, to make sure they're going in the right direction, to make sure they don't actually need an oral steroid to treat this, and see if they need to still step up. When I know they have good control, so if they come back and they're doing the same or better at that follow-up, or if they're doing better at that follow-up, you actually want to maintain the same therapy for a full 3 months before you step down. And I set this expectation for patients. If you step down too soon, you're going to rebound, you're going to be on inhalers longer. So especially if you're starting a maintenance twice a day, you kind of have to sell it to them like, look, if you come down earlier, you're going to be on this longer. And I see it time and time again. So 3 months is really how much you want to wait on a good therapy so they're not using their breakthrough inhaler often. And that brings me to the asthma control test. So this is how I reassess. This is something in our office, it's easy. We don't have as many forms as primary care doctors, so our MAs can give this to the patient. I'll have it's laid out a little better here. So there is 5 questions, and then they answer on a scale of 1 to 5 for each of them. So did asthma keep you from getting out much and getting things done out of the home and inside the home? Did you have shortness of breath? How often have you had symptoms that wake you up at night or in the morning? How often have you needed your rescue inhalers? And how would you rate your control? So and then below is like the scale. So 3 or more times a day, all the way to not at all. And then they circle a number and then you add it up. So there's 5 questions, there's 5 questions, a total of 5. So they can get 25 points total. When I'm moving quickly and I only have time for 1 question, this is the question that works best for me. It's like, how much are you using your rescue inhaler? Really, if they're answering 4 or 5 on this, then they're in pretty good control and you can keep them there. If they're only really using it once a week, then they're in good control. But in general, we like the asthma control test to have greater than 20 points. If they're poorly controlled, then it's under 20. So if you're answering all 4s and 5s, then you'll be pretty much all 5s and 1 4, you'll be okay. So this is again emphasizes you can step up within a week or even sooner, but you don't want to step down until you have 3 months of good control. Which brings us to post-viral asthma. So when I talk about this, I will also talk about other triggers of asthma because it kind of the way you approach post-viral asthma is no different really than other asthma exacerbation triggers, but it really helps to set expectations for patients. So I'm going to start with a case because actually over the last year, I've had a really good case of this with pulmonary function tests, which is not always the case. Normally you're getting PFTs for the first time after their first presentation, but I had a 46-year-old firefighter, and so they had their health physicals. He was getting physicals every year and had PFTs for like 3 years. And the PFTs had showed obstruction since 2021, but he never had any respiratory issues. He was a diver. He was on site for his job and never had limitations. But he got COVID in August 2022. And after that, for 3 months, he had cough with exertion, chest tightness with exertion, and really just overall fatigue. He'd never smoked. Like I said, smoke exposures were associated with work. He was a rescue diver as well, but never had issues with that underwater. His PFTs from before COVID were similar. So if you look here, he's younger. So his lower limit of normal is 72, but he was under that at 65 or 0.65. His FEV1 was 3.1 liters, which was 80%. His FVC was 4.7 liters, which was 95%, but that ratio was still below the lower limit of normal. Then when I saw him, his PFTs were actually the same. He had more symptoms, but the PFTs are maybe even a little better. So the ratio is 72. At this point, his reference was 73 on our machine. And again, like his FVC was 100% predicted. So he's a good reserve, and that's why he didn't feel it for so long. But now he's feeling symptoms. So he has obstruction. So triggers for asthma, number one is viral illness. So that's why you're seeing so much post-viral asthma, or you don't know if it is post-viral asthma or not, because this is the number one cause of triggering asthma. People present in their 20s, 30s, 60s, 80s with their first episode of asthma related to a viral illness. And there's no good data on how many times, like with the percentage of people who will continue to have asthma or won't after a post-viral asthma episode. Unfortunately, there's not good numbers. In my clinical practice, the people who come to see me, I'd say about 75% of people still need inhalers intermittently after their first exposure like this. Other things, allergens. So if they're getting symptomatic during the spring or during alder season, which is end of winter, pollution's a problem, probably even more here than we see in Seattle, but from the wildfires, and then smoking, of course. And then thinking about the host comorbidities is important. So obesity, smoking, acid reflux, and rhinosinusitis are the main things that are going to make asthma harder to control. Things you can do a lot about quickly is really the rhinosinusitis. So getting sinus disease controlled will really help. The lung disease, obesity, and GERD you're working on already for so many other reasons, and that's harder to stay on top of. Some people are just frequent exacerbators. And the other thing to think of is this a young person who had a knee injury and they were taking NSAIDs. And the combination of NSAIDs and a virus is a reason why they flared for the first time. So putting NSAID use in your history when you're talking to people about asthma is a good thing to keep in the back of your head. And sometimes I even forget to do, but it really can help, because if they have a little bit of runny nose and NSAID sensitivity, then taking out the NSAID might be all they need to not have the exacerbation with the next virus. This is just a schematic of like all the things that play into what causes us to have asthma or not. So the environmental exposures, the host factors, and then at the bottom in all the boxes is all the signaling cascades, which will bring me into the biologics that we'll talk about for asthma. But there's a lot of different inflammatory components that we are able to target now, and some that we will soon be able to target. So again, for these patients, the post-viral asthmas, setting expectations, lots of times they need twice-a-day inhalers, if not steroids and inhalers. If you're starting steroids, please also start an inhaled corticosteroid. And then when they're done with the steroids, they should continue that inhaled corticosteroid for at least 3 months. See them back. If they're doing really well, then you trial off of it. And a lot of people I actually taper down to 1 puff a day and then come off. And then I advise them to keep an unopened inhaler on them. And if they get another viral illness, to start taking it right away at the onset of that illness to avoid the prolonged bronchoreactivity that could happen afterwards. And like I said, will they have another flare? There's no good numbers out there. In my clinical practice, a lot of them do, but some of them don't if we're able to target and see like, oh, you were on NSAIDs and there were other causes here. Other allergens to think about, the NIH let out, there's a ton of environmental data, and environmental studies are really hard to, because there's so many confounding factors. But the NIH tried to compile all of the environmental interventions to say like which ones are worthwhile and which ones aren't. So I wanted to talk about that. Basically, if your patient has a history that they go to, when they're at home, they have exacerbations, they really have exacerbations around cats around a certain time of year. If they have a clinical history that makes you think, there might be an environmental component, then yes, you can get allergy testing. Otherwise, they say don't do it. And that's really because the allergy testing is really going to help you if you end up choosing to do immunotherapy. So that's shots to then make them less reactive to that allergen. And so otherwise, you're just going to do environmental mediation, which could potentially help anyone. As far as what interventions help in the home, getting rid of insects or criticides doesn't really do anything. But dust mite covers is very beneficial. There's actually a lot of studies on this. So if patients have bad asthma, they're in a dusty atmosphere, I really try to get them to get pillow covers, a mattress cover that's dust mite impermeable, so that then there's been shown that this can decrease asthma exacerbations. Also getting rid of all insects isn't helpful. Specifically targeting cockroaches can be, but I think that's more that when people end up moving out of certain environments, it gets better, but the data shows that can help. Getting rid of carpet and big drapery, which we always ask them about as pulmonologists, that doesn't actually show to help. And this one's hard to put on here for me because I like air purifiers for air pollution, but for allergies, it doesn't actually do anything. A big in-home room air purifier wouldn't. Now it does for air pollution, so I'll talk about that next. What helps for allergens is a HEPA filter vacuum has been shown to help. So if patients are really sensitive to dust mites, it's another component that can help them out. As far as getting rid of a fomite or a pet, that's in the middle, and I have never tried to do that for a patient. We have just done lifestyle modifications around a pet, but trying to not get rid of their fluffy friends. And then these are kind of just outlines of recommendations I give my patients when fire season's coming. I know hopefully we're coming to the end of this year, but it can go all the way to end of October and November. So I just want patients to have their controller meds, the complete set of them at home so they're able to use their inhalers in times of poor air quality. And then while they're in the office, I ask them, oh, how do you check air quality? And lots of times now they can just pull up on their phone, the weather app, and it's on there. If not, we talk about which channel they can listen to on the news to find out what the AQI or air quality index is, and what number is going to be bad for them once they're in the orange zone or the yellow zone. And then optimizing indoor air quality. So air filters do work, whether it's a very expensive one or a box fan with a 3M air filter on the back of it. It doesn't really matter. What I try to have them do, especially if their house is bigger, is have a clean air room where that box fan is running all the time during poor air quality to keep the particulate matter in the home lower. I remind them that cooking, especially meats, anything on the stove is going to increase the particulate matter in your house. So not good to do during bad air quality, and not to bring in firewood for heating during time of poor air quality. And then vacuuming, actually, although it's good to get rid of particulates, when you vacuum, the air quality goes down for about 4 hours. The particulate levels just skyrockets for about 4 hours, and then it comes back down while things settle. So not a good time to do house cleaning. About masks, this comes up even more now because people have more access to masks since the pandemic. N95s can help with the particulate matter, but it doesn't do anything for the carbon monoxide, the nitric dioxides, or all the other gases. So ideally staying indoors is better. And with the mask, it has to be perfectly fitted tight for the particulate matter to make a difference. So yes, you can wear it if you have to go out, but the best thing is to stay indoors. Okay, I have enough time to dive into biologics. Don't have to focus on the slide at all. It's just to show you kind of the multitude of targets we have now for asthma. So we're not just doing inhalers, we're going at specific targets now. So everything in the circles are the inflammatory factors that lead to the type 2 or type 1 immunity that we're trying to intervene to stop asthma flares. The stuff that's blue, we have a target for, we have a medication, and the other ones we're close. Green is close, yellow is a little further away. So when I'm thinking about what biologic to use, what I like to do is order CBC with differential, so I can look at the eosinophil level, and an IgE, and then I get all the other immunoglobulins because you have to do the immunoglobulins with their counterparts to make sure it's not inappropriately off. I didn't include the IgE levels here because that is more straightforward. There's a cutoff for labs and you can just go off that. But for IgE, anything over 300 to 500 is kind of positive. And if they're in the thousands, we think of things like ABPA and other things. For eosinophil levels, we don't care about the percent, we care about the absolute number. So this guy, it says 0.97. In the nomenclature in all the studies, they'll call that 970. So move the decimal 2.2 places. So their level is, or 3 places, sorry, is 970. This patient isn't even determined to have high eosinophils, but hers is 470. So the cutoff for eosinophilic asthma is 150, which is actually normal. So you can have a normal amount of eosinophils and still have an eosinophilic asthma that will respond to the biologics, which is great. So we can treat more people. But now we have drugs to even treat people who are non-eosinophilic, which is nice. So this is for your poorly controlled asthmatics. They're probably seeing a pulmonologist as well. They're going to be group step 3, 4, or 5, or 6, normally 4, 5, or 6. Don't need to take a picture of this. There's just a lot that goes into what we decide to use. So their EL level, whether they're dependent on steroids, do they have any other components of disease? Do they have nasal disease? Do they have esophageal disease with eosinophilic esophagitis? So there's a lot that goes into what we choose. This table kind of summarizes the active biologics we're using now in the US. You'll see some other names, ruxolitinib, that we don't use in the US, that they use in Europe. So benralizumab and mepolizumab, Fasenra and Nucala, are the two eosinophilic targeters. So they target IL-5 and the IL-5 receptor. And basically, once you knock out IL-5, you're taking out the fertilizer for eosinophils. So white blood cells do not become eosinophils. So you just don't have them anymore. So you don't get eosinophilic flares. You don't need that many eosinophils to qualify. So the studies enrolled people with 150 or above. So it works for ages 12 and up and 6 and up for both these drugs. Mepolizumab, for some reason, it's been on the market a little longer than Fasenra. So it's approved for eosinophilic esophagitis. We use it for eosinophilic vasculitis, or EGPA, and then uncontrolled eosinophilic asthma. Most of the time, they're in a pen, which is really nice. It's like an EpiPen. It infuses slowly, and then you give it every 2 to 8 weeks, 4 for Nucala, and then 8 weeks for Fasenra. Dupixent, or is the third one down on the list. It actually is not targeting IL-5. It targets IL-4 receptor alpha. So it does not wash out the eosinophil levels. Though a patient will still have EOs, they actually may have higher EOs because they might produce more to try to overcome this. But that's okay because they're inactive eosinophils. And this also has a lot of indications. Sinus disease, it just got, there's studies that show benefit in COPD. I think it's been FDA approved, but I have not gotten insurance to cover it for COPD years. But any kind of eosinophilic tending diseases of the airway, it's very helpful. And that's every 2 weeks. Xolair is the oldest of them. It's the IgE. And so that's more of the aeroallergenic type. And their IgE levels are higher. And then the new one, anti-TSLP, or Tespri, I've actually only prescribed it twice and just getting patients started on it. It's been out for a year, and this is for the non-eosinophilic asthmatics. But basically, the guidelines I'm going to give you for all the other biologics kind of fit for that as well. Side effects for these drugs, I kind of compiled it, so it's not just to give you an idea, because they're very similar. So injection site pain, there's a little bit of pain with the needle, and actually patients really complain that when the medicine infuses, it hurts. It's just a lot of pressure. Headaches is common, especially in the first couple of doses. Fatigue, especially with Nucala, I've seen that. It tends to wear off by 3 months, but they can be tired at first. Sore throat, conjunctivitis, this was in Dupixent studies. Actually, but it was not that much more than the placebo, so unknown if that's really true. Joint aches was seen with Xolair and Nucala, but patients have reported fear of that with any of these biologics. And then the eosinophilic flare is something to be aware of for Dupixent. Since it's not getting rid of the eosinophils and you actually have a higher count, for some patients, you can develop an EGPA, or eosinophilic vasculitis type reaction. It's very rare. Or an eosinophilic pneumonia type reaction. So I have had one patient I took off of it because he was doing great for 3 months. And then for the next 3 months was just starting to do bad again, and like had a rash, and his eosinophil count doesn't matter to monitor it. But I was just worried he was going in the direction of a flare there. So we switched into Nucala. But in general, Dupixent works really well. And I have not seen a full EGPA from it clinically. The severe allergenic reaction, you're going to have a risk of that with any kind of infusion. Just like the biologics for rheumatoid arthritis, these are expensive, but we get them covered, and there's really good assistance programs. Sometimes there's a lot of paperwork back and forth, but we're able to get it covered for most Medicare patients and private insurance patients. So it would be, sometimes it's $2,000 a month copay, but a lot of that is covered. Even if their W-2 doesn't show they need it, they still can fill out Dupixent My Way and get some help. So it makes it easier. Okay, so when can they be administered? So there's a lot less limitations with our biologics than the rheumatologic biologics, as I'm very proud of. It just is easier to manage. So if they have hypertension, if they have fever, chest pain, if they're hospitalized for pneumonia, respiratory illness, if they're on antibiotics, if they're about to have surgery, if they just had surgery, all of these things, it's okay to still give. Headache, pregnancy, and breastfeeding, I'll talk about in a little bit. And vaccines, there's one caveat. So you don't want to give them, though. You see in the middle there is there's not checks down the line of active helminth infections. So you need eosinophils to treat those. I have yet to diagnose a helminth infection in someone on one of these. It may happen. Maybe if my patient travels to East Africa for 3 months, I might hold it. I don't know. I haven't run into that yet. As far as live attenuated vaccines, MMR was the drug of question or vaccine of question. Or varicella vaccine, but now we have the inactive vaccine. So you can substitute that way. And it's just for Dupixent. Nucala and Fasenra, the other IL-5s are okay to continue. And the reason why we don't use it in Dupixent, I think just because they didn't in the study. If someone had a live attenuated vaccine, they had to be 3 months out from that vaccine to be enrolled into the study. It's just a thought of lower efficacy of the vaccine. It's not going to be a complication for the patient. Same thing for the rheumatologic component, but should not be a problem with the vaccines we're using now. So you can go forward with all the vaccines. There are some websites, this is actually all wrong, pretty much. There's some websites that will tell you Dupixent interacts with cytochrome P450, but it's not really that. It's a theoretical risk because you have decreased inflammation. The thought is your cytochrome can be better active because you're less inflamed. So there's concern that a lot of drugs that use this enzyme to process could go up in their levels. That is not true with the bottom ones, but with warfarin, if someone's on warfarin, I do just have them get their INR checked like a couple weeks after starting it if they're not on a regular INR check, just to make sure, but it's theoretical. And it's not, you won't see it on all the drug interaction websites, only some of them. Breastfeeding and pregnancy. So we would not start a biologic while someone's pregnant. If they are pregnant, it's a risk-benefit discussion with the provider. We tend to continue it as we do other medications, and there's not a theoretical risk to the infant. Same with breastfeeding. Okay, well, I'm moving fast. So I'll have any questions on the biologics before I move into the bonus pearls. Okay, looks like I've covered everything. Good. Okay. And I will start talking a little slower because we have time. So I wanted to go over just pulmonary function tests. I'm not going to go over these in detail, but just kind of reminding people when we order what and what to think about when you're seeing the primary care office, what to order. If you're not sure, if you just order spirometry and diffusion capacity, that always is a great start. But anytime we're worried about airflow obstruction or upper airway obstruction, we get spirometry. So you need the full loop. For some PFT labs, they have flow volume curve and flow volume loop. The loop gives you the inspiratory and expiratory. So you need the full loop if you're worried about upper airway obstruction. For lung volumes, we really need that if we're worried about emphysema. Interstitial lung disease, we'll get it not every time, but at least once, because following their full lung volume is helpful. And also for obesity, if we think obesity is really contributing, actually it's kind of nice because your ERV goes down a lot, which is it's a calculated measurement. It's the estimated reserve volume. And that's unproportionately affected if in obese patients. So if that's the only thing that's different, then I'm kind of able to say, this is all we're finding. This might be your weight. Let's focus on that. And then diffusion capacity we get for unexplained dyspnea and if we're concerned for interstitial lung disease. And also if we want to tease out asthma versus emphysema. Asthma tends to have a high DLCO. Emphysema has a lower DLCO. So looking at inhalers, so this was like 2007. No, 2007. And this is 2016. So this is like even a fraction of what we have now. There are so many inhalers, and we're really limited by what insurance covers. So going over the nomenclature real quick, the dried powder inhalers are good. They have great delivery. The problem is they have a really short half-life. Once the patient opens the dried packet they come in, they only have 3 months to use it because the powder will harden and they won't actually get any powder on the puff. So that one's important to stay within their 3-month window. For the HFAs, it's in a liquid and it suspends better and it has a longer shelf life. So patients who have albuterol that's 3 years old, it actually still works. Same with Symbicort. So, and Dulera, we want them to replace it annually, but there's efficacy that's almost at the same level of pharmacokinetically at 3 years than 1 year with the HFAs. So if cost is a problem, but they have one and they can use their old one, I do advise that that's okay with the HFAs, not with the DPIs. And then using aero chambers is very helpful. So we have these in our office, so it's easy to distribute, but you can also prescribe them. Just we have a form that we fill out in our own clinic, but you can just write a hand prescription or an automated one on the computer just to dispense a spacer and just use one. And they work really well with the HFAs. They decrease thrush. So I move with anyone who's having a lot of thrush, I try to move to an HFA with a spacer. And I see that they have less thrush and less need for nystatin washes. These are the current pearls I have for low-cost alternatives, and these change like every year to 2 years. But right now, Air Duo, which is the same thing, same medications as Advair, but it's in an L-shaped DPI. So they just open it up, the medicine's ready, and they do an inhalation. So they can get that with GoodRx for $40 to $60 at pretty much any pharmacy. I think CVS has the lowest price one. So they print out the prescription, and that's good for a year of refills. Advair, the 250/50, you're able to get at Cost Plus Drugs. So you send your prescription to Cost Plus Drugs for $60. So this is the workaround I use for my patients who need to be on 2 inhalers or if nothing is covered. And then for nebulizer stuff, I actually recommend patients go to Amazon or nebulizers.com and just like forget using the pharmacies for that. We also have them handed out in clinics, so sometimes it's easier to get them to a pulmonologist because we can set all that stuff up and you don't have to worry about us, and then we'll send them back to you. So if you're just having troubles getting the meds they need, you can send them to us to set things up, basically. That leads into asthma in the elderly. So the main issue here is it's harder to diagnose because there's so many things that contribute to dyspnea in our elderly population. And COPD could be heart failure, it could be COPD. It's harder for them even to do the pulmonary function test. So interpreting the test is harder. We have to look at the curves and see the quality of the test as well. And then what I didn't put on here is that it's harder for them to use the inhalers. Yeah, it's more challenging. So with some patients, we try the spacer to see if that works, but even the timing of that's hard because you push it in and you don't have to breathe in right away. You don't have to time it, but that can still be difficult. So for a lot of patients who are elderly, I do move to nebulized medications because then someone can put it in and they can more passively receive it. If they're not able to, if they live alone though and are trying to do the nebulizer, that can be hard because of dexterity. But those are some of the things we try. And then they get oral candidiasis more often. They'll get the hoarseness, and I put bone density on there. They're likely getting DEXAs anyway and can have poor density. The ICSs should not contribute too much to that, but they might end up ingesting more than a younger person using the same inhaler. COVID and asthma. So patients with mild to moderate asthma, well, so they're not at increased risk of getting it, and they're not at increased risk of severe disease or death related to COVID, which is good. However, if they've been on steroids or they recently had a flare, then they are at risk of worse outcomes for COVID. So pretty much with all of my asthmatics, I give them the option to take Paxlovid if it doesn't interact with their other medications, especially if they've been on steroids even within the last year. But it's recent steroid use that makes us more concerned about outcomes for the patient. I don't know about the newest, this is all from systemic reviews from earlier this year. So with the newest mutation and the current immunity level, that might be changing. Another pearl, so cough variant asthma. This one's really hard because we know asthma can cause cough along with upper airway cough syndrome, acid reflux, medications. So, and a lot of times these asthma is not like chest tightness. They don't have the classic asthma symptoms. And a lot of times PFTs are normal. So ideally, if we're able to downtown, we do methylcholine challenges to diagnose asthma. But sometimes we can't. So we actually just do an empiric treatment with inhaled corticosteroids. Now, a lot of times patients come to me and their primary have tried albuterol for their cough. That's not really going to work because they're not having they're not able to time it well enough with the cough to make it go away. Like sometimes you can do it before they would normally get a cough, but a lot of times you need an anti-inflammatory. So a good 2-week trial of an inhaled corticosteroid, if you want to try to treat them for a cough-bearing asthma, if you think that could be a component, is better than a trial of albuterol. And normally you have to treat the GERD and the upper airway cough syndrome at the same time because inevitably they'll have some rhinosinusitis as well. So exercise-induced asthma, because I've been talking about inhaled corticosteroids all the time, we normally use short-acting bronchodilators before you exercise. So that kind of goes against what all the new updates are to really focus on inhaled corticosteroids. So what I do, if patients don't exercise that much, I say, okay, whatever, you're only using your short-acting bronchodilator 3 times a week, that's fine. But if they're using it more than that, I give them an inhaled corticosteroid to use, either the combo, I give them Symbicort or Dulera to use before they exercise, or I give them albuterol and then an inhaled steroid to use at night on the days they've used their albuterol, just to decrease that inflammation and keep the beta receptors up. Some things, if they can't tolerate short-acting bronchodilators, I've had a run of athletes who get their heart rate up too much. So I've tried Singulair and Spiriva. Spiriva doesn't work as much, but Singulair might help, especially if they're eosinophilic. And then lastly, asthma and exercise. So a lot of my patients ask, well, what else can I do besides using this inhaler? I need something else. Like I don't want to be taking medicine. So exercise has been shown to independently help asthma outcomes. Of course, they have to be breathing well enough to exercise, but when someone is exercising regularly, asthma is better controlled. And they think, and now we don't know cause, or we don't know what direction that causation goes, but there's some studies to think that independent of weight loss, exercise can help asthma, and weight loss does as well. Lastly, when to refer to pulmonary. So if there's difficulties establishing a diagnosis of asthma, if treatment really isn't working, or if there's anything abnormal in chest imaging or the pulmonary function test, we like to see them. If they've had hospitalizations, frequent exacerbations, or steroid dependency, we like to see them as well. So I'll summarize the take-homes. Prescribe an inhaled corticosteroid if patients are using albuterol up to 3 times a week. That's kind of like what I do, and that way you can make sure you're covering all your bases, what Gina has taught us from their guidelines and what the NIH knows is feasible with our medical system and our prescription system. If patients are using, the MART therapy, prescribe different ICS-LABA medications. So one is a rescue with the formoterol, and then one is twice a day. And that might help decrease their exacerbations because they're getting more inhaled steroids in. They might need less oral steroids. Post-viral asthma, so treat for 3 months to get good control for 3 months with BID, ICS. And then once they've shown good control at that 3-month mark, you can step them down and keep an inhaler on hand for the next URI. And then hold Dupixent for 3 months if you're going to give a live attenuated vaccine. Otherwise, it's okay to give for any vaccine. And there's no need to hold a biologic, except if your patient has a helminth infection, other than the vaccine that I mentioned before. So that's it. I included my email. I should have put my phone number on there too. I really love to be in contact. A couple of people emailed me after my last talk out here, and that was really nice. So please feel free. If you didn't get the slides and you want them, I'm happy to send them. And any questions? Good. I will let you guys go to lunch 10 minutes early then.